Hello my dear students, I'm Dr. Divya DSa. Welcome to my channel Case Anatomy. In Anatomy in Practice series, I take anatomy beyond the books. I'll show you how anatomical concepts come to life in clinical practice, making anatomy all the more relevant, engaging and indispensable. So hit the subscribe, ring the bell and join me. So before we dive into the injuries of median nerve, let's quickly recall the formation, the course and the branches of median nerve. So the median nerve root value is C5, C6, C7, C8 and C1. Since it is formed by the lateral root of median derived from the lateral cord and medial root of median given by the medial cord. It is formed in the axilla in front of the third part of axillary artery. It enters the arm, initially being on the lateral side and then crosses at the mid-arm from lateral to medial side, and in the elbow, that is in the cubital fossa, it lies medial to the brachial artery. It leaves the elbow, that is the cubital fossa, by passing between the two heads of the pronator teres muscle, and once there it gives the anterior interosseous nerve which supplies the deeper muscles. So here in the forearm, the median nerve is mainly motor. So it supplies all these superficial muscles except for flexor carpi ulnaris, and through its deep branch supplies the deep muscles except for the medial half of the flexor digitorum profundus. Then it enters the flexor retinaculum, and just before it enters the flexor retinaculum, it gives the palmar cutaneous branch which supplies the lateral 3/4 of the skin over the palm. And once it enters the flexor retinaculum, it divides into the lateral and medial branches. Lateral branch gives a recurrent branch which supplies the thenar muscles, and they also give branch to the lateral and medial divisions. They give branches to the lumbricals too, and they supply the 3.5 lateral 3.5 digits, as well as on the dorsal aspect they supply the nail beds and the distal half of the 3.5 digits. The median nerve on the palmar aspect of the hand supplies the lateral 3/4 of the palm as well as the lateral 3.5 digits. And on the dorsal aspect of the hand, it supplies the nail beds as well as the distal half of the lateral 3.5 digits. Now let's look at the sites of injuries of median nerve. So the lesions of median nerve may occur at the following 4 sites. One is at the elbow, at mid forearm, at the wrist or distal forearm, and in the carpal tunnel. Now let's look at the causes of injury of median nerve at the elbow. So the most common cause is application of tight tourniquet during venipuncture. Supracondylar fracture of the humerus can cause injury of the median nerve, and entrapment of the nerve into conditions, that is by the Steucher's ligament and between the two heads of pronator teres during its course, and also by the fibrous arch connecting the radial and the ulnar head of flexor digitorum superficialis. Let's now understand the clinical features of injury of median nerve at the elbow. The clinical features include the forearm in a supinated position, and this is because of loss of pronation due to paralysis of pronator teres and pronator quadratus, which is supplied by the median nerve and the anterior interosseous nerves, which is a branch of the median nerve respectively. There is weakness in the flexion of the wrist. So this is because of the paralysis of all the flexors of the forearm except the medial half of flexor digitorum profundus and flexor carpi ulnaris, and these two are supplied by the ulnar nerve. There is adduction of the wrist. This is because of the paralysis of flexor carpi radialis muscles, which is supplied by the median nerve, and unopposed action of flexor carpi ulnaris and medial half of flexor digitorum profundus, which is supplied by the ulnar nerve. Then there is loss of flexion at the interphalangeal joints of index and middle finger because of the paralysis of flexor digitorum superficialis as well as the lateral half of flexor digitorum profundus. There is loss of flexion of the terminal phalanx of the thumb, and this is because of the paralysis of flexor pollicis longus tendon, which is supplied by the anterior interosseous nerve, which is the branch of median nerve. Then there is loss of sensation in the lateral 3/4 surface of the palm. This is because of the involvement of palmar-cutaneous branch of the median nerve. Loss of sensation over the lateral 3½ digits as well as on the dorsal aspect, that is the distal half of the dorsal surface of the hand. So basically the digits. Here it is because of the involvement of the medial and lateral branches of the median nerve. There are two types of deformities of the hand associated with the injury of the median nerve. One is the benediction type of deformity of the hand. So what is this? So here, when the patient tries to make a fist, the index and the middle finger, they remain straight. That is because there is paralysis of both flexor digitorum superficialis and flexor digitorum profundus tendon. So the tendons of these two muscles, which goes to index and middle finger, they are paralyzed. The ring and the little finger can be flexed. Okay, so this is because there is intact nerve supply of the medial half of flexor digitorum profundus, which is supplied by the ulnar nerve. The benediction deformity is also known as papal benediction deformity. So this has a very interesting story. It was first used by Pope Peter, and it is thought that this unique gesture, in which the thumb is tucked into the palm and the index and the middle finger are raised together, may have been due to nerve damage. And this gesture even today is used by the Pope to give congregational blessings. The other type of deformity we see is the eighth thumb deformity. Here the thenar eminence is flattened because of the paralysis of thenar muscles, which are supplied by the recurrent branch, which is given by the lateral division of the median nerve. And the thumb is adducted, and this is because of the unopposed action of adductor pollicis, which is supplied by the ulnar nerve. Now let's look at the clinical features of injury of median nerve at the mid forearm. So one of the clinical features is pointing index finger. This is because of the paralysis of radial head of flexor digitorum superficialis tendon. So this flexor digitorum superficialis tendon, one of the tendon of it goes to the index finger, and it brings about the flexion of the proximal interphalangeal joint. And because that is lost, we get this pointing index finger. Then we have the eighth thumb deformity. Here, this is because of the paralysis of thenar muscles. Loss of sensation in the lateral 3/4 of the palm because of the involvement of the palmar-cutaneous branch. And there is loss of sensation in the lateral 3½ digits as well as loss of sensation on the dorsal aspect of the distal half of 3½ digits. And this is because of the involvement of medial and lateral branches of the median nerve. So when the patient is asked to make a fist, he will not be able to flex the index finger of the affected hand, and this is because of the paralysis of radial head of flexor digitorum superficialis muscle. At the wrist, the median nerve and its palmar-cutaneous branch may be injured just proximal to the flexor retinaculum by deep lacerated wounds, such as in suicidal cuts. So let's look at the clinical features of injury at the wrist. So here we see the eighth thumb deformity because of the paralysis of thenar muscles, which is supplied by the recurrent branch given by the lateral division of the median nerve. Then there is loss of sensation in the lateral 3/4 of the palm because of the involvement of palmar-cutaneous branch. There is loss of sensation in the lateral 3½ digits, as well as loss of sensation on the dorsal aspect of distal half of 3½ digits. and this is because of the involvement of medial and lateral branches of the median nerve. The commonest injury of the median nerve occurs at the carpal tunnel. Now this carpal tunnel is formed by the flexor retinaculum and the concavity of the carpal bones, and through this tunnel passes all the long flexor tendons of the fingers as along with the synovial sheath as well as the median nerve. Now the median nerve here, it can get compressed and because of the narrowing due to many pathological conditions. So let's see the common causes of carpal tunnel syndrome. So the most common cause is tenosynovitis of the flexor tendons in myxedema and retention of fluid in pregnancy. So in pregnancy there will be retention of fluid in the limbs. So because of these things we can see some of the trophic changes that includes dry and scaly skin, easily cracking nails and atrophy of the pulp of the fingers. The other causes of carpal tunnel syndrome include osteoarthritis of the wrist and fracture dislocation of the lunate bone. Let's now understand the clinical features of injury of median nerve at the carpal tunnel. There is pins and needles sensation, that is a feeling of burning sensation over the lateral 3.5 digits. This is basically because of the compression of the median nerve and involvement of these two divisions, that is the lateral and medial divisions which supply these digits. Then there is weakness of the thenar muscles because of the involvement of recurrent branch of median nerve that is given by the lateral division. There is no sensory loss over the lateral 3/4 of the palm because the palmar cutaneous branch is not involved here since it is given before the median nerve enters the flexor, and that is before it passes beneath the flexor retinaculum or into the carpal tunnel. Then aphthous deformity can occur if this condition is left untreated. So carpal tunnel syndrome is mainly because of the compression of the nerve. So in case it is left untreated, it can result in the paralysis. So aphthous deformity can occur because of the paralysis of the thenar muscles. There are few tests which helps in the diagnosis of carpal tunnel syndrome, and one is the Tinel sign. Here percussion over the flexor retinaculum reproduces the patient's symptoms. So there is sensations of pins and needles or burning sensation over the area of distribution of the median nerve. The other test is the Fallon's test. Here the flexion of both the wrists against each other for 1 minute, it reproduces the patient's symptoms. Thus, a positive Tinel sign, a positive Fallon's test, and reduced conduction velocity in the median nerve is diagnostic of carpal tunnel syndrome. And that's a wrap for today's episode of Anatomy in Practice. I believe I helped you connect the dots between theory and clinical correlation. So if you found this video helpful, don't forget to like, subscribe, and share it with your friends. Hit the bell icon so that you never miss out on the next episode of exploration into the practical wonders of anatomy. See you in the next series. Until then, happy learning.